All right, I think we can get started. My name is Rick Labuda with Chiari. I am joined by Dr. Robert Friedlander from UPMC and Dr. Jeffery Greenfield from Columbia, who just both gave tremendous presentations. Unfortunately, Dr. Petra Klinga was unable to join us for the Q&A session. I hope everyone enjoyed her presentation as well. We did have quite a few questions, so I am going to jump right in to some of these, and some will be for both, and some will be for one versus another of the surgeons. So an easy question to start for both of you. Why don't we start with Dr. Friedlander? How long after surgery do you continue to follow your patients for?
So again, pleasure to be with you here today. Usually my typical post-op management is patients go home. Again, most of them are going home post-operative day one these days. I see them 2 weeks after, where we get the sutures out. If they have a syrinx, I would re-image them at 3 months, and I'd follow those a little different than patients that never had a syrinx. Those I follow a little bit longer. If there's no syrinx, I usually see them at 6-month follow-up, and if everything is fine, then I don't follow them any longer. Obviously, they know how to find us if they have any issues.
Sure, of course. Dr. Greenfield?
Sure. Again, I reiterate with what Bob said. Thanks for hosting us today, and hopefully this will be a fun opportunity for everyone to learn a little bit. My philosophy is a little bit different and just mandated a little bit by some of the IRB protocols that I put into place. I like to follow my patients up to about a year, basically just to get quality of life metrics and outcome metrics as far as I can. In terms of the immediate post-op period, I try to see everyone at around the 3-month mark. And you'll hear, if you query 10 surgeons, you'll get 10 slightly different answers. The key is obviously to have communication with your doctor, have open lines with their office. Seeing someone at 2 weeks doesn't mean that you're not going to have a problem at 3 weeks, or seeing someone at 3 months doesn't mean you're not going to have a problem at 4 months. So, these are guidelines. That's basically an opportunity for us to make sure that we're tracking progress and that healing is going well. And as long as you communicate with your surgeon on the follow-up plans, any of these rubrics will work fine.
Okay, thank you. Let's stay with Dr. Greenfield. In your presentation, you did show a case when you were talking about retroflex odontoid that was quite severe. So I assume that was an obvious decision as far as treatment. I assume you also see many cases where the retroflexion is not as severe and maybe not as severe kinking of the brainstem. How would you describe kind of your thought process or your guidelines as to when you would do an anterior decompression versus a posterior, or both? Do you ever do both?
Yeah, it's a wonderful question, and I'll mention that I feel like the audience here and the patients that are seeing Dr. Friedlander and I are increasingly becoming more and more well-educated on the conditions, the imaging. They come with really sophisticated questions. And this is a pretty sophisticated question, but I think it's maybe taken on too much of a life of its own, this question of the retroflex odontoid. It really is part of the Chiari morphology. A vast majority of patients with Chiari, particularly Chiari 1.5, which makes up a disproportionate number of symptomatic patients, they'll have a retroflex odontoid, and the overwhelming majority of them will not need to have any surgery to address that pathology. A standard posterior decompression is going to, in my practice, in my experience, address symptoms the vast majority of the time. I showed a severe example where the brainstem was being kinked and compressed for obvious purposes to demonstrate severe pathology and to make it clear how that's different than the normal pathology. In terms of how often anterior pathology needs to be addressed, it's a vast minority of patients. And in terms of anterior and posterior, I will almost never do an anterior approach without first trying a posterior approach and giving 3 months or 6 months or a year to assess symptom resolution, because the posterior approach is so successful. And then in terms of the anterior approach, what people don't necessarily always realize when they come and ask about it is that an anterior approach to take down the odontoid process, and by virtue of that, usually the ring of C1, also mandates a cervical fusion. So it's not just decompressing bone, it's a 360-degree stabilization and decompression. So you're taking a standard decompression, you're turning it into a really big operation with, a year-long recovery. So it's a totally different pathology in my estimation.
Sure. Dr. Friedlander, would you like to comment?
Actually, yeah, my approach is very, very similar to what has been described just now. Very rarely we do front back, and again, really, I mimic what Jeff said. Is the vast majority of patients you can take care of from behind. Both of us are actually in institutions that have a great endonasal surgeons to work with. So again, doing the anterior decompression is something that we can do, as well as the fusions, but the vast majority of them don't require that.
And it's worth just following what Dr. Friedlander said. The endonasal approach has completely changed at Pittsburgh and at Cornell. We don't do transoral operations any longer. You don't need to in the vast majority of cases as well. So although it's a big operation because you need to be fused, the actual resection of the odontoid through an endonasal approach is not a terribly painful or difficult surgery anymore the way it used to be. It's just not needed that often.
So you used to have to break the jaw, right? Essentially.
At least go through the mouth and sometimes the back of the throat, back of the tongue. A very different operation than we can do now through the nose and the sinuses.
Okay. Going back to Dr. Friedlander, you spoke quite a bit about head numbness, and someone wanted to know if you see it more often on the right side, the left side, equal, and they also wanted to know what specifically do you think causes the hand numbness in Chiari?
So the hand numbness, it's often symmetric, but it could be one side or the other, and it's likely a compression on the dorsal columns of the spinal cord and just the sensory pathways in general. But it's one of the first questions I ask my patients when I see them in the recovery room: how's your hand numbness? And that often is the first symptom to get better. And it's you have to distinguish it from cervical disc as an example, which is more, as I mentioned, radicular type of complaint, where you have really a streak of numbness could be from the elbow, from the shoulder down to the hands, not necessarily symmetric for the whole hand. So it's a very common complaint, and again, with more severe cases, you have numbness in the arms and the legs. But that is, again, it's one of the first symptoms to get better almost immediately after surgery.
Okay, thank you, Dr. Greenfield. If a child is decompressed, has Chiari, symptomatic Chiari, decompressed, a younger child, and then later on in puberty they develop scoliosis, how do you differentiate, or how do you what's your thought process in addressing the scoliosis through correction versus potentially revisiting the Chiari?
Wow, that's a pretty advanced question. It's an excellent question. So my hospital is across the street from the hospital for special surgery. So they literally see like 1,000 kids a year for scoliosis. So we see a ton of these kids, and it's very interesting to see the evolution of thought in this, because it used to be that the orthopedic surgeons wouldn't actually ever scan the spinal cord unless there was some significant neurologic problem, and I think that's evolved over the course of the time that I've been there to the point now where I think they scan everybody literally, because one or two bad outcomes or unexpected neurologic outcomes after scoliosis correction has sort of changed that rubric. So we see all of these cases and have started to have to make some of these tougher decisions about what to do. For children who have not had decompression and they're evaluated and find that they have scoliosis, get an MRI scan, and they've got significant brainstem compression, the question that we've always debated in the field is, can Chiari alone cause scoliosis in the absence of syringomyelia? It's always thought traditionally been that it's the syringomyelia and the spinal cord dysfunction that then leads to the scoliosis. So you fix the Chiari and that gets better. The question is that narrow gap. What if you have Chiari and not syringomyelia? Can that also cause scoliosis? And similar to what Dr. Friedlander said, there's clearly brainstem compression and asymmetric compression of descending fibers. And so I think people are evolving to think that that is just as likely to be a contributing source to the scoliosis as the syringomyelia. And so if there's significant brainstem compression, it'd be a very balanced and open conversation with the family. Say, let's balance the risks of doing a revision Chiari surgery if there's compression of your brainstem to try and minimize the need to have, a larger scoliosis operation. It's always balancing one operation versus the other, with the understanding that if it doesn't work, you still might end up getting scoliosis surgery. If it does, maybe you avoid a bigger surgery. But it's a very nuanced question, and I'm not sure there's an answer that I can say is definitive. It's more of a risk assessment and assessment of how bad that compression might be.
Sure. Thank you. Back to Dr. Friedlander. Let me preface this by saying that on the Conquer Chiari website, pregnancy-related articles are by far the most read and the most popular. So in general, the question is, have you treated patients whose Chiari became symptomatic during pregnancy or labor? And are you concerned about epidurals during labor causing, a change in pressure, sparking, worsening symptoms, things like that?
So it's obviously several questions at once, and again, a sophisticated question. I'll separate it into different parts. The epidural component, if the tap is a wet tap and there's leakage of fluid, there's certainly a possibility of a sump type of effect where CSF is leaking from below, and you can have a mild Chiari become a mild and asymptomatic Chiari become a symptomatic Chiari, and then you need to address the root cause of the issue, which is the leakage of fluid. With a delivery, obviously millions of deliveries every year, and the likelihood of a asymptomatic Chiari becoming symptomatic is small, but it does happen. With there might be some element of a trauma. In some of the earlier talks this morning, we were discussing, there is a correlation with, why does a Chiari become symptomatic, particularly in adults at a certain age? What's happened? And we often hear, somebody who's predisposed, likely, and then has a mild trauma and is going through the labor trauma. Well, I guess ladies would say yes. I mean, it's a fairly traumatic event with a lot of different physiological changes in the brain, with swelling and Valsalva and all of that. So certainly it's something that we do see at times. The reverse question is somebody with a known Chiari with mild symptoms going through delivery. We always we have a high risk OB group that will go and evaluate the patients, and we talk with them. So if it's asymptomatic and they want to do a vaginal delivery, we try to do a rapid type of induction and delivery there. And others, we recommend a C-section. Really depends on the full picture of the patient. What does the imaging look like? What are they? What symptoms they have, but it's a tailored approach is really the rule here. It's hard to have a formula for everybody.
Sure. Thank you, Dr. Greenfield. The earlier presentations, including Dr. Friedlander's, highlighted the psychological symptoms often associated with Chiari in adults. Do you see similar type symptoms in children, pediatric cases with depression, anxiety, those types of things?
Yeah, I think this is another one of those evolving fields where I think we're all starting to, coalesce a little bit behind the idea that there are neurocognitive effects of Chiari, and there's been growing literature to support this. The difficulty that I've always encountered in the pediatric population as compared to the adult population is, there's such a wide spectrum of developmental variability, and the ability of, parents to have to advocate for their kids is a little bit of a confounder. School performance can be linked to so many different variables. We've tried to, incorporate as many preoperative metrics as we can. And for a while, we were really quite interested in the idea of doing preoperative neurocognitive assessments, a very short neuropsych evaluation with our, neuropsychologists. And it became prohibitively difficult, unfortunately, because insurance companies didn't love the idea of doing this. They didn't feel like it was a necessary adjunct and wasn't adding anything. And so the question was either, well, we could do it with students and sort of untrained professionals doing the assessments, or abandon it. And so we've just gotten some people doing some PhD work actually in the neuropsych department who are interested, and we're going to be sort of firing that study back up again, because you really need to do pre-operative and then post-operative assessments to get any real data on it. My own feeling is that I truly do believe that there's this brain fog and cognitive dysfunction, whether it's related to chronic neurologic disability, pain, comorbid depression and anxiety. That's going to be really hard to untangle. But I do know that the patients, self-report those feelings going away after surgery a tremendous percentage of the time. And what I usually tell, adult patients when they ask me, is that going to go away? I said, look, I think let's focus on, the debilitating headaches and dizziness and numbness. And if you feel better and the cognitive issues improve, I'll take that, and that'll be a bonus on top of it. But I'm not going to predict that because we don't have great evidence in the literature yet, even though I'm quite suspicious that we'll find what we all expect that we will find.
That's a nice segue into the next question that I was going to ask both of you is, what do you tell in general your patients about what symptoms, are likely to improve versus which ones may not? Dr. Friedlander?
So, what I tell them is that, the most typical symptoms tend to improve, meaning the Valsalva-associated headache, numbness and tingling, ringing in the ears, swallowing. Those are fairly typical ones. The blurry vision, again, usually patients that come in with visual complaints, I send them to our neuro-ophthalmologist just to make sure there's nothing else going on. So those are more likely to improve. Chiari patients can come in with a vast number of neurological complaints or symptoms. And I always like to inject a little bit of humor as part of the evaluation. So I tell them if something gets better, I'll take full credit for it. And if it did, then I say, I told you so. And again, obviously, they understand it's a joke in a way, but many symptoms tend to get better. And I think it's within the whole realm of really feeling better and well-being and the brain fog clearing.
What about balance issues? Do you find that among adults, the balance issues tend to clear up or not?
They tend to. I don't find them as a very common complaint. Certainly, some patients do have it. Vertigo and balance, and we have that evaluated. And it's one of those that's just a little less common in my experience.
Dr. Greenfield, did you want to add anything?
Yeah, I think that again, we're very much on the same wavelength here in terms of how we approach and how we get informed consent, and expectation setting for patients is very important. The most useful guidance that I give and tool that I use for my adults, we have a very different metric for judging success in Chiari than we do in many other realms of neurosurgery. Post-operative MRI scan for tumor patients, or obliteration of an aneurysm. Those are definitive things that we can measure and see and define. For Chiari, I think whether or not a patient feels like they're better off having had the surgery at 3 months, unfortunately, is sort of like the best metric. Like, are you glad you had the surgery? Like, are you better overall? It's such a terribly imprecise and non-scientific question. But I think that gives me an overall sense of, am I making good decisions, or am I advocating for surgery for the right patients? And as long as that number is somewhere, in the close to 90%, I think you're doing a really good job in the Chiari world. You can't hit 100%. I don't think, we try to, and I think we continue to get better at assessing who's going to do well with surgery. But I think we want our patients to feel like it was worth it, that they feel like their quality of life is better. And, one patient's, symptom relief that they might judge as a 9, maybe another person simply they judge at a 3. And so there's so many subjective criteria involved in making these assessments that I just want the patients to be happy and feel like they, are in a better place than they were before surgery. And that's a success.
Sure. All right, here's one that has come in while we've been speaking. When does a syrinx cross the line of just being monitored to needing surgery if there are no associated symptoms?
I think it's quite different for adults and pediatric. On the my view on the adult side is that if it's asymptomatic, if on a first visit it's asymptomatic, particularly the smaller ones, I would watch with any sense of any new symptom. even if it's mild, that I think that crosses the line. Really haven't seen too many patients that have a syrinx that enlarges with no symptoms. So it's a pretty unusual circumstance.
Right. That's probably more common among children, I would assume, right?
Yeah, but my philosophy is very similar. I think, again, over the last 10 years, I have evolved to observe more and more asymptomatic kids with syrinx. There's a little bit of angst, I think, because you're dealing with parents as well. And the aspect of needing to monitor them with serial imaging and sometimes sedation. So there's definitely a little bit of an added layer of nuance that goes into it, probably with kids. But I definitely feel comfortable monitoring kids who are asymptomatic.
Is there a certain percentage of the cord width that kind of triggers you thinking, now maybe that's something we need to address? Or?
There really isn't, Rick. I mean, I've seen kids come into my office with complete holosyrinx cords top to bottom that we assume are congenital, that have literally not a symptom, not a reflex out of whack. And then you've got patients with really what you would deem to be insignificant syrinxes who have pain or numbness or what you believe are referable symptoms. So it's one of these things that's hard to match up. The one criteria that I use is that an increasing syrinx typically leads me to push for surgery a little bit more, because I think, as Dr. Friedlander says, they usually don't grow. So when they're growing, you can sort of predict the natural history that there is really an obstruction of CSF flow.
Right.
And you don't want to get into that place where you're behind the 8-ball. But I think that's a smaller percentage than you might imagine. Most kids I monitor and are stable, and surgery is done for symptom relief, not because of the syrinx.
Right. Let's stay with the hydrodynamics for a second. And I think one complication, surgical complication, that does not necessarily receive as much attention as it should, is the development of hydrocephalus after decompression surgery. I was wondering if you could each kind of comment on if you see that, how you avoid it, and whether you have any thoughts on what actually causes it to occur.
Well, great question. I've put a ton of thought into this because the question is there a certain percentage of Chiari patients that come in with increased intracranial pressure, irrespective of the Chiari? So again, there's some patients, with a pseudotumor type of picture, and it's something that we're doing, putting them over the edge. So what is it that we're doing? I think there's particularly two components that can exacerbate the need for needing a shunt. One is, blood in the CSF space. So I am a militant about really trying to avoid a red blood cell inside the CSF. Obviously, it happens, it's surgery, but I do everything that I can to try to avoid any blood during the opening and the closure into the CSF spaces. The other is a reaction to the graft, chemical meningitis, and I've tried a number of different grafts. And as an example, when I was in Boston, this is over 12 years ago, I always used alloderm, very low rates of shunting. And then when I first came here, I was using bovine pericardium, and all of a sudden my shunting rate goes up, and I was like, what's different? Is it the air in Pittsburgh, or is it something I'm doing?
Which it could be.
Well, yeah, but then I went back to the alloderm, and my rates came down very, very significantly after that. So I think there's things that we're doing that are part of the process. So that's my thought on that.
So if blood gets into the CSF, are you saying that somehow disrupts the body's natural production absorption cycle?
Yeah, I think for a patient who's right on the edge, and if you have some blood in the CSF, it gets cleared up, it gets reabsorbed through the natural channels of reabsorption of CSF. Blood, like it happens in subarachnoid hemorrhages, can clog up that to some extent. So if a patient is right at the edge, but I have no proof for any of this.
Right.
These are just my thoughts at this point.
Someone just chimed in real quick. What is the alloderm patch? What type of graft is that? What's the composition?
So alloderm, it comes from human cadaver skin that's completely decellularized. So it's all a human protein, essentially collagen for the most part. So that's right. What that is. I like the way it handles, and again, the reactions that I get are pretty low. I soak it for a long time before, from the beginning of surgery. So it's soaking and really clearing any other chemicals.
Do you ever use any dural sealant, or do you just? So,
I used to use dural sealant all the time just because it makes you feel good. It's a blue material and it looks great and it makes you feel good. And then one day I decided, you know what? I don't know if this makes a difference. So I stopped it. And I would say for 90% of my cases, I don't. There's some patients that have very thin duras, or as you're putting the sutures, there's a hole that you try to patch with a little muscle patch or different techniques. But there's some that I just feel, I just want a little extra. So I use the dural sealant. But as I said, for the most part, I don't.
okay. Dr. Greenfield, would you like to comment on the hydrocephalus and what your preferred graft material is?
Yeah, this is like a million different little nuances here in one. I agree with Dr. Friedlander again. I'm sorry we're so agreeable with each other
That's
here, but I
okay.
think lots of experience here is very similar. You know, the blood cells and the meticulousness, I think, is really key. I think I do pericranium, which is sort of, you know, autologous tissue from a site underneath the scalp. I don't think that's the main reason why I don't have any significant rates of postoperative hydrocephalus. I think the reason that I've been successful in avoiding leaks and pseudomeningoceles and hydrocephalus is largely because I'm militant, like Dr. Friedlander, in the preoperative workup and making sure that patients don't have those risk factors. You know, I think I got burned once very early in my career, not recognizing a patient with pseudotumor. So now I'm probably a little bit over, you know, I do a little bit too much of a workup sometimes, perhaps, to rule this out. Everyone gets ophthalmology. A good percentage of patients who are borderline will get ICP monitors a day or two before surgery. And I think the fact that I don't have those complications now is more a reflection of picking the right patients, making sure they get on ICP lowering medication, and doing everything you can in the surgery itself to minimize inflammation and red blood cells. And so the other thing that I do, which my partners and I know a lot of other neurosurgeons don't do, so we can discuss that, is I'm a strong believer in steroids after surgery, and I do it for, you know, anywhere from 10 to 14 days, a very, very low dose. And there are definitely some pros and cons to that, but it minimizes post-op headaches. I think it minimizes the inflammation, and I've had really good success with it. And again, and like anything in surgery, once you sort of develop a technique and a routine, it's hard to change it because you feel comfortable with it. But that's definitely not something that everyone does.
Again, I agree with you on the steroids as well. I you know, preoperatively give them steroids, and then while they're in the hospital, they're on 4Q6. Obviously, it's adults of Decadron, and when they're discharged, do a Medrol dose pack. So again, it's maybe a little
lot of
shorter.
our colleagues don't use it though, so it's interesting. Yeah, I think it definitely helps.
Yeah.
So let me ask this. You are agreeing on a lot of things, and you both have, you know, good success in minimizing complications. When would you advise a patient to seek out a surgeon with extensive Chiari experience? You know, is it only the complicated cases?
Well, that's an easy question. I think that there's no straightforward Chiari operation, because the first operation is the most important operation, and both Jeff and I are, you know, we see a lot of redo surgeries, and that it's significantly more complicated. There's some people who are doing very minimally invasive procedures, but again, they don't really take care of all the things that need to be taken care of, or some huge incisions that really destabilize the musculature. And for me, as I see, like every additional 100 operations that I've done of Chiari, I'm a better surgeon. But both, not that both the technical component, but the nuances and the different things that we learn. So it's the kind of thing that I don't think there's just a chip shot easy Chiari operation, because the first one is the most important. Well, what happens before the ORs, the decision-making process, is the most important in the nuanced part. Yeah, there are the patients that are very easy to figure out. Yeah, this is a symptomatic Chiari, but as I said in my presentation, there's a lot of that gray. And if you say, I'm only going to operate on the straightforward ones, then there's a bunch of patients that you're just not helping that you can help. So it's really deciding on those there. So what happens before the ORs, incredibly important. Obviously, what happens in the OR is incredibly important. So somebody with lots of experience really makes a difference here.
I'm going to steal that. I like that line. The first operation is the most important one. I'm not used that one, but I'll credit you. I like that. And the other thing that I think is important for experienced surgeons in any field, and again, whether it's a tumor or an aneurysm or a Chiari, when you're picking a surgeon, you're not picking a surgeon to handle the routine part of the case. You're picking someone in case something unusual occurs or something unusual is seen. And there's an unusual complication post-operatively. Someone who's done hundreds of these surgeries is going to be better equipped to deal with those unusual situations. Yes, most people who graduate from my program, my residents who have done dozens of these with me, they know how to take care of it, and I expect they can go out and take care of a patient well, but it's the unexpected part of the practice that is where you'll be happy to have someone like Dr. Friedlander, following you. I think it's just a different set of confidence and skills that you gain and continue to gain as you mature through your career.
Someone just wanted to clarify that, Dr. Greenfield, you treat both pediatric and adult patients, correct?
I do, yes, yeah.
Oh,
I'm
okay.
a trained pediatric neurosurgeon, and the adult Chiari patients are really the only population of adults along with tethered cord that I take care of. So it's mostly
Okay.
just congenital. I don't do other adult surgeries except for tethered cord and Chiari.
Thanks for clarifying. I'm going to read this question. I will admit I don't completely understand it, but we'll see what you guys say. Are there any thoughts regarding elongated styloids causing IJV compression that could influence idiopathic intracranial hypertension that should be addressed prior to Chiari decompression?
Jeff, I'll leave that one to you.
Yeah, I don't. Yeah, I'm aware of this phenomenon, and some patients have brought it to my attention. I think the best way of thinking about these phenomenon is really in the rubric that Dr. Friedlander and I have discussed, and I talked about it in my presentation at length, which is you have to rule out all of these comorbid conditions first. And whether the IH is due to jugular vein compression or obesity or transverse venous stenosis, I think all these etiologies are becoming better understood. I'm very comfortable getting MRVs and sending these patients to my interventional team. I'd much rather someone get a venous sinus stent than go down the road of Chiari surgery and have complications and leaks and shunts. So I think it just falls under this, kind of do the preoperative workup, make sure this is not a secondary Chiari from an underlying etiology like idiopathic intracranial hypertension. We're learning more about this. On the other side of the equation, I think we're learning a ton more about CSF leaks and all of these very subtle fistula and opportunities for herniation to be propagated that are really outside the realm of our normal imaging capabilities to identify. And so a lot of this is just listening to the patients and getting the nuances. Is this really something that sounds more like Chiari, or something that is maybe more a positional headache or a morning headache, or something that can be ascribed to IH or CSF leak, and being compulsive about that. I don't have any experience with the styloid processes or surgeries for it, but clearly there are experts out there who do, and that's part of the preoperative workup to make sure you're not missing a secondary Chiari.
Along those lines, and we are quickly running out of time, but along those lines, how do you screen for connective tissue disorders if someone hasn't already been diagnosed when they come in? What are the triggers in your mind that say I need to, really pursue this as a connective tissue disorder case?
Yeah, I mean, that's a hard one, because I think, so many people are told that they need to get a genetics evaluation or get testing, and really there are no true markers. Everyone is aware of the fact that most of the hypermobile collagen disorders don't have true markers. I mean, we see kids with Down syndrome and other rare connective tissue disorders. We're talking about the vast majority of kids and young adults don't have them. And so my screen is pretty simple. I mean, everyone knows the Baton score, but I asked to look at other scars. Have they healed inappropriately? Have they had dislocations? In my pediatric patients, they almost all end up having a history of being in gymnastics or ballet. They're incredibly hypermobile, and they know their history, and if they don't know their diagnosis. But the more important part of this is, I think that, doctors who see a ton of Chiari patients, I think we all sort of approach it the same way. I'm curious if Dr. Friedlander feels like this, but I don't really necessarily have a different operative philosophy in patients who I know have EDS or don't. I mean, I kind of assume that everyone has something a little funny going on, and my technique and the way we close the dura and the way we close the muscle, I think we assume that everyone is going to be a unique patient, and I don't like to be surprised in the back end. And so whether or not they have EDS or not, I kind of do the surgery the same way as if they all have.
But as far as the workup, do you do the dynamic MRI and everyone with deflection? Is that everyone goes through that, or only if you suspect something triggers you to suspect instability?
Yeah, that's got to be a trigger question. No, everyone does not get that entire workup. There are $1 million workups you can do for that, and for patients who I think have instability, that's a whole different conversation, and they end up, getting collars and flexion extension films. That's true. Most patients don't need that workup, and again, if you get the right operation, a standard Chiari decompression operation done in a meticulous fashion is not going to, in my experience, lead to instability that wasn't already there prior. It just the instability that's created by surgery are really over-aggressive surgeries where huge decompressions and muscle dissection are done. And again, that comes back to the nuance of the surgery and going to someone who's experienced in it.
Yeah, I again completely agree with this. If somebody doesn't have gross instability preoperatively, I treat them all the same. I do the surgery, and I'm doing, it as little as possible, but as much as needed to accomplish the goal and what you need to do. More and more, as I mentioned in my talk, I'm leaving C1 behind, just drilling the top of C1. I think leaving all the musculature attached below C1 makes a difference. Patients seem to have less pain, but again, hard to prove because I just have myself to compare my old patients to my new patients. But it's again, really having that philosophy of doing as little as needed, as little as possible, but as much as needed. Really is the way I approach these patients.
Okay. One last question. I think I know the answer, but we'll toss it out. But do either of you have experience with research done around stem cell for the damage caused by a syrinx? Stem cell treatments?
I don't.
No.
I don't either.
I believe the literature has 1 or 2 case studies in Europe that have been fairly equivocal in their results. Do you have any comments, Dr. Greenfield?
The only comment I'll make about this, but I think it comes from a really important place, the question about what to do about syrinx, because I think that, well, Dr. Friedlander and I, treat syrinx and are, the surgery is really successful at treating syrinx. I tell my patients to think of syrinx that has caused neurologic disability as like along the same rubric as a spinal cord injury. It is an injury to the cord, and it is trauma, and surgery to fix the syrinx doesn't necessarily fix the underlying dysfunction in those. And so the question is really coming from a place of, well, how do I fix the underlying problem? Because I think we've all had patients where we've had incredible post-operative radiology results and the massive syrinx decrease, and really terrible persistent arm pain or debilitating back or neck pain has persisted. And that's a spinal cord injury, and it feels bad because you think, well, the scan looks so good, but whether it's stem cell treatments or things that yet are under development, I think there'll be opportunities for investigation there, but it's not so much related to the Chiari as it is more related to long-term damage. And I think probably see that more in adults than in kids.
Yep. All right. Well, I want to thank you both for your time. It was a great session, and we're going to end it there. Thanks again for your time.
Yeah, thank you very much.
Thanks for having us, Rick. Take care.